Our last paper of the morning is a...
Afternoon.
It's the afternoon?
Yes.
Oh, buonasera. No, I'm not in Italy anymore. There's going to be a case series of percutaneous sonography guided contracture release. Fabian Moungondo. Also, while they're setting up, I just want to remind everybody, if you're going to the Congress dinner, which is a culinary walking tour of Brussels, if you signed up for that, we're going to meet in the lobby at 7:30 p.m. when we hit the afternoon.
Okay, so good morning, everyone. I'm Fabian Moungondo. I'm working in Brussels. I'm upper limb and hand surgeon. And it's an honor for me to talk about our small series of sono-guided relief of Dupuytren contracture. These are my disclosures. And go to the procedure. We, in our department, are using sonography to release Dupuytren cords. We are using high-frequency probe and no tourniquet with local anesthesia, no adrenaline, no incision. We are performing multiple cutting of cords from the palm to the finger, and we are not doing joint release, and we are not doing injection of corticoids. This is the technique from outside and inside. We start with local anesthesia. It's a progressive anesthesia. Then we do an entry point with a catheter, and we cut the cord. Here we can see that I'm cutting the cord at the level of the volar arch. We can see the small nerves and artery just aside the tendon. And after that, we can do the same distally, very close to the pedicle. We see the pedicle side to the tendon. After we extend the finger, and once it's good, we stop once the patient is happy because he is awake also, he can see. So here is this patient before the release and after the procedure, and 12 days after. The patient just have a wound dressing for 12 hours and after nothing. For the pinky and also for very protrusive cord, we can use a bath to do that underwater. It's good because with the probe we don't have to be in contact with the skin, and we can very well control the cutting of the cord, and we will see everything under the skin. So this is the first case. It's a 67-year-old man with Tubiana-2 fourth and fifth finger contracture. So first, we do local anesthesia. Here we can see the artery that is beating just under the fluid that is injected. That this is hydrodissection that can give place for us to work. And then with the cutting instrument we are cutting, we can see the artery just under the instrument. Because we see everything, we can advance the instrument very carefully. And here is what we are doing more distally close to the finger. This is this patient before and after the release. And this patient the recurrency after 2 years, and you can see the images that we had 2 years after the procedure. So we perform the exactly same procedure. This is the second case. It's a 63-year-old male with tubular contracture just in the finger. In this case, we did the same. You can see on the inner side of the finger, all the entry points. We come laterally, not in front of the cord. Here is the patient 5 days after the procedure. Finally, the third case, here is a 80-year-old woman who have 2 fingers with tubiana 2 and 3. And we perform the same procedure. As you can see here, the result is not so bad. Our experience is we start in 2020 very slowly, and our experience is increasing. We have 188 digits. Most are the fourth and fifth finger, and the mean time is 28 minutes. Here we can see that we performed last year a retrospective study of the first cases. It's based on the medical file review. It's a single surgeon series. We had 76 patients, 119 digits. Most was male. The mean follow-up was 6 months. As you can see here, this is the result in terms of resolution of the contraction. We see that we have a good improvement just after the procedure, but there is a big limit of this study is that the patient, they don't come back to the outpatient. As you can see, at 24 months, there may be 7 patients who just come back to the outpatient clinic. So we need to organize a retrospective interventional study where we call back the patient to better assess the result. And we need also to assess them at 5 years post-operatively. Complications, we had in these cases, all these patients, 6 cases of skin rupture during extension. We had also in this patient, a single patient who had a dysesthesia of the 5th finger after the release. What about the recurrency? There was 4 patients who had to be reoperated because of the recurrency of the contracture. Or when we see all the recurrency, we can see that it was between 100 and 900 days after the procedure. And the same procedure was performed. If we look on the literature, we can see that it's scarce. There is not a lot of cases. When I look on PubMed, there was just 1 case report and 3 retrospective studies with very small cohorts. And most of the time, the procedure was associated with other procedure. So to conclude, this technique is efficient, it's very accurate, but it's technically demanding because there is a very steep learning curve, and the recurrency can be treated in the same manner. This is an advantage, but there is a risk for a nerve lesion, so we really need to be careful and be very, very well trained. Finally, we need long follow-up to better know if it's better or the same than blind technique or other procedures. Thank you for your attention.
Fabian, can I ask a question? You differentiated between recurrence and residual tissue. So when you see you have residual tissue at the end of your treatment, do you convert to open surgery or you leave it like?
No, at the end of the release, if I did all I could and I cannot have a complete extension, I ask the patient, I show his hand, what do you think about this? Okay. And he say, oh, it's very nice for me. So we left like this. And maybe with the time I will improve my skills and be very more performant. Maybe I will have better result. But we don't want to do a joint procedure, and we want also to avoid to have nerve lesion, because even if it's under sonography, when we are in the 5th finger, distally it's very difficult to see the nerve. Mm-hmm. Maybe with a new machine, with a high-frequency probe, maybe we will be able to see more things at this level.
Questions?
Other questions?
Thank you very much. Sorry, can you just go back over what exactly the device is that cuts the cord? I'm not clear, I'm sorry. What is it, the thing? Is it working on heat? How does it cut the cord?
We are using a Sparker device, and it's a device that was built for the trigger finger percutaneous release under sonography.
It's a push knife, so the blade is at the tip, and you push
it's like a big needle with. The tip is a blade, but the blade is not as sharp as a knife. So it's quite safe when you touch a tendon. It's difficult to cut a tendon with that, or even you can push a nerve without cutting it. But to cut, you have to do a specific movement.
There's a workshop for spire cut. They'll be here tomorrow as opposed to the other two workshops. There's also a therapy session, 1746, on Creative Room 5, and the Belgian hand group's going to meet after we're done. Any other questions? Paul?
Thank you very much. It seems to me that you're a very dexterous surgeon,
He is.
and I wonder if you need this expensive spire cut, if I'm right. Why don't you just use a needle? So if you're considering to do a prospective study, I would challenge you to compare your results with the results of just needle fasciotomy, because I'm convinced
Blind fasciotomy or with the sonography? Or you know, probably it will be the same, because the needle, you have to modify the needle, because you cannot use the needle as it was shown by our moderator before, because you use sonography, so you cannot come on the top. You put the probe on the top, so you come from the side. So you can use a needle, but you have to modify to bend the needle. And then you will work with a small needle, and the needle, you have to think about also the bevel of the needle. The bevel of the needle is quite sharp. With this instrument, it's not so sharp, so it's probably it's less dangerous, probably, because of course we should do a study. But you also have to keep in one fact, is that the bevels of the needles are changing, because the company that are doing the needle, sometimes they change the needle, and you are not averted of this change. In my hospital, they decide to, this was the hospital rule, they decide to change for a needle that cannot, that is not sharp for to retrieve fluid. And then I was using rose needle. I was quite annoyed, because I start with the needle, and also the needle tip changed with the same references. With the time, I observed that the tip changed, and one day the needle you are using will just disappear. This is why we need specific instrumentation. You're welcome.
Yes, Charlie?
Sterility and immersion is the hand
Yes.
underwater?
Yeah.
And so you prep the entire hand and you use sterile?
So there is this quite of bath, and we put sterile fields twice around the hand, and then we put it into the bath. Then we put sterile saline inside, and we don't need a lot of water, because we just need to immerse the finger inside. But all the hand is there is disinfection with betadine or ibutan.
Thank you very, very much. The Belgian Congress is going to go now, I guess.